Okay, we will start. We already discussed last week about the differential diagnosis of bilious and non-bilious emesis. That's Dr. Van Roff, the main textbook for the neonatology, the main guy for the neonates, like Nilsson in pediatric. So we discuss about projectile vomiting, or very good for those people to summarize what we've been taught. So we said any baby who has a vomiting, it's always make sure that you're systematic. Is it baby has projectile vomiting versus non-projectile? We discussed that the baby has a projectile vomiting, that means go far away. It could be gastric outflow obstruction, and mainly we are talking about pyloric stenosis, or increased intracranial pressure. If baby has non-projectile, then it has various causes. It could be bilious, that means bile, come with greenish yellow, or non-bilious vomiting. The non-bilious vomiting, it could be bloody, or it could be non-bloody. Blood, it could be fresh blood, or it could be coffee ground, depending on the presentation. And then we discussed about pyloric stenosis last time. Feel free to look at online. We discuss about the antral whip, and then we come to the small intestinal obstructions. We discuss how to approach very quick for people, the GI joint. They did not catch the last lecture. We said if you have the bowel and non-specific, or you did like you're concerned about abdominal distension, baby has either bilious or non-bilious vomiting, you're going to start with the, after a good history and exam, you're going to do the x-ray. We discuss if baby has double bubble sign. Specifically, you're going to look below. If there's any, if there is no distal gas, then your differential diagnosis, top of differential diagnosis, duodenatresia. And I will talk about something else that just we have it in our unit, giving double bubble sign, and then we diagnosed duodenatresia antenatally, and then baby after birth, we had the surgery, and we will show you the image. Inshallah, we will discuss. Also, so always double bubble sign, any distal air, no, then most likely duodenatresia or any obstruction duodenum. If there is distal air, then you need to follow with the upper GI serial or series. If baby has multiple fluid level, you ask yourself, any distal air? If it's absent, there's no distal air all the way to the rectum, there's no distal air, then you start with the lower GI. You do lower, it's depend. So if the baby presented with distal air absent, just you think of, okay, where's the fluid level? Is it higher? Then it could be baby has malrotation, especially if baby came with bilious vomiting. Always bilious vomiting, malrotation, volvulus still improve otherwise. That's, keep it in your mind. So it's always, we need to rule out malrotation. In this case, it's better to start with upper GI to make sure there's no malrotation or there's no volvulus. If things came back fine, then you can do the lower GI with the contrast enema. We said we don't use the barium anymore because the risk of the perforation and then can cause peritonitis. If the distal air present, then you start with the lower, with the barium enema or the contrast enema, not barium, sorry. We discussed about duodenal atresia, we discussed about pathophysiology, different type, and we discussed about treatment. And also we covered the small bowel obstruction. We discussed about triple bubble signs, اللي هي jejunal atresia, and then also we discussed about the ileal atresia. Okay, so the case that I have it last week, baby who born, we know the case, antenatal, we discussed in the, we usually have a rounds where we sit with all OBGY, the high risk rounds, maternal fetal medicine, we sit together and we discuss about all the expected delivery, high risk deliveries. And one of the cases that they presented, that baby expected to have duodenatresia based on the perinatal ultrasound. And then baby born, the abdomen soft. We keep the baby MBO because we know this baby has double bubble sign. They note on the antenatal care. So we call the surgeon. The surgeon, she evaluate the baby. She looked at the X-ray, and that's the admission X-ray. As you can see, this is the chest X-ray. Looks well expanded, but I'm focused. I'm going to be pointed. Today is not the lecture how to read X-ray, but we're going to focus on what you see now. So here you can see there is a big bubble, and there's second bubble. So, and we discussed the last time when we, and I asked a couple of my nurses when we do the regular round or the night round, and we have like this case, I'm trying to ask them where this double bubble or the second bubble come from. The second bubble come from when it passed the pylorus, that's the second bubble, and then there is atresia here. So this is the first bubble, and here's the pylorus, and then there is second bubble on the prior or proximal to the atresia. So that's the double bubble. So now we said this baby most likely, as we discussed, duodenal atresia, baby born, NG feet place, MBO, suction, or if there is nothing, then we can leave it with the gravity. And then we call baby started already fluid. He has a central line with the UVC, TBN running. And then we call the surgeon. The surgeon looked at the X-ray. He said, yes, duodenal atresia is not an emergency. We will schedule surgery for this baby. So surprisingly, during the surgery, this baby does not have duodenal atresia. And what this baby has, he has obstruction here. So what's this obstruction? Baby has annular pancreas. So the pancreas surrounding, and you can see here, and obstruct the duodenum. Create double bubble sign or the obstruction, which looks like duodenal atresia. So in this case, when you have the double bubble sign, is not always, most common is duodenal atresia. You need to make sure that's not duodenal atresia. So the baby is going to go to the OR regardless. So during OR, we have surprised baby has the annular pancreas. And that's the pancreas surrounding and complete obstruction of the duodenum. Okay, this baby went to the OR, a duodenostomy. So they make connection between both duodenum, and they left the pancreas alone. Okay, so that's an interesting case I would like to share with you guys. Just we have it recently. Okay, so the second topic we're going to discuss, malrotation with volvulus. That's one of the very, very important. The board, they love it, and we need to go through it. And at the end of this presentation, I want to make sure everybody understands malrotation very well. So malrotation and volvulus, what does it mean? That means arrest of the, so we know the bowel usually rotate 270 degrees. If the bowel arrested of the normal gut rotation, that's what's called malrotation. And usually when the bowel rotates, it takes with it superior mesenteric artery, as we discussed in previous presentation, and even before that, we said that the gastric tube, when started, the thoracic or the abdominal aorta, the three branches. So we have we said that the gastric tube, we have foregut, we have midgut, and we have the hindgut. And each one has different blood supply. So we said the foregut supplied by the celiac trunk. We said the midgut supplied by the superior mesenteric artery. And we said the hindgut supplied by the inferior mesenteric artery. So that's why we are talking here about superior mesenteric artery. So during the normal rotation, when the bowel gets rotate, it take with the rotate also is not only for the bowel, it's going to also take with it superior mesenteric artery. Failure of the gut to rotate, that's when cause malrotation, okay, or completely rotate, failure to complete rotate. So let's talk about the stages of the normal rotation. So you can see here around the first stage, around 6 months of age, or initially what happens, the midgut go ventral toward the umbilical cord. So it's go this way, around 6 weeks of age. And then go that way, down. And you can see the superior mesenteric rotate with it. Go all the way, stretch it down. and then the rotation occur. So you have initially a 90-degree rotation and then 180. Let's discuss. So let's look at my hand. So hopefully I can explain nice way. So the bowel, usually my thumb is the cecum. Just remember, my thumb is the cecum. So we know normally the cecum should be right lower quadrant. On the right lower quadrant, that's my cecum. Okay. So early in the development, the cecum located on the left side. And then the bowel, what happens? Number one, it's 90-degree rotation. So where's located now? More at the right upper quadrant. That's the 90-degree. If the baby has malrotation, stop here. That's malrotation, where you find the cecum in the right upper quadrant. After that, the bowel rotates all the way down to the 180 degree, all the way down to 100. So you have initially 90 plus 180. Now we rotate to 170 degree. Is that clear? I'm going to repeat it the last time, and then we can look at this one image. Or let's look at the image before we explain it again. So you can see here, focus on the cecum diverticulum. As I said, initially the bowel go vertically, and then it's going to rotate 90 degrees. So now the cecum located at the right upper quadrant. After that, the bowel or the cecum rotate, or the whole bowel rotate all the way to the 180 degree. So it's going to come all the way to the right lower quadrant. If you see here 90 and then 180, so we are reached 270. Is that clear? That's very important. And I'm talking about mid-gut rotation here. Okay, so cecum diverticulum rotate the whole, take the whole bowel to the 90 degree and then all the way to 180. In malrotation, what happened in malrotation? Malrotation is failure the bowel to rotate 180 degree. Okay, so what does mean? If the bowel failed to rotate, complete rotate, that means stay in the 100, then after 90 degree. So now you are talking about the cecum located at right upper quadrant, failure to go down. So it's supposed to be here, it doesn't go down. Also normal during the bowel rotation, so that's normal. Also during the normal rotation, this superior mesenteric also stretch with the rotation. So let's go with the same rotation. So let's go toward from here all the way down and then branching, supporting the whole colon in the right position and is not flipping. When you have malrotation, what happens? Number one, the cecum all the way at the right upper quadrant. Number two, also the superior mesenteric affected. So superior mesenteric, instead of staying all the way down, descended, plus giving branch to cover and make like web, the shabaka, to cover the whole bowel, so bowel stays steady. It doesn't happen. So what happens here? The bowel, the superior mesenteric stay in the same place. Also, the third issue with malrotation. So we said number one, remain in the right upper quadrant. Number two, the effect on the superior mesenteric migration or the normal growth rotation. Number three, the fibrous band formation, which is called the lead band, which is made from the fibrous. So what's the issue with malrotation? Malrotation can be diagnosed early and can be late. Nobody knows. Later on, adolescent, adult, it might be presented with symptoms. Anytime you have malrotation, number one, the risk of the land band, as you can see here, let me clear it up. The land band can compress the same way like when we discuss about annular pancreas, can compress on the duodenum and cause distal duodenal obstruction. So I need you guys to pay attention to this, okay? So number one, the lead band can obstruct the duodenum. So baby has malrotation, the lead band, the right upper quadrant, can obstruct the duodenum and can cause duodenal obstruction, either acute or subacute or subchronic. Also, because of the failure of the superior mesenteric to descend and make a web or cover the hole and make the bowel in the steady or not rotating, now the bowel is freely rotate, and that's increased risk of Malrotation Volvulus. So what happens? The bowel become loose, and that's increased risk of volvulus. So that the volvulus is a true emergency. So when your baby has volvulus, it's really a true emergency, okay? So that's very good. So again, when you have the malrotation, number one, the risk of obstruction of the bowel, of the duodenum. Number two, which is more acute emergency. That's why we always say, if you have a baby who just born with bilious vomiting, that يعني إن هو الvomit greenish yellow, always surgical till improve otherwise. That means you need to call surgery. Keep baby MBO, Reblogal, which is large suction tube. Keep it with for decompression, either with the gravity or low intermittent suction. And a baby has a lot of secretion, maybe you can even continue suction. We prefer low intermittent suction because sometimes the suction tube close to the gastric mucosa with continuous suction can cause erosion. Then, if you are concerned about infection, you might start prophylactic antibiotic. Majority of time, unless it's concerned, we don't start. We call the surgeon. We do KOB, X-ray, and then we call the surgeon. The surgeon, the moment he hears bilious vomiting, persistent, usually they recommend, especially if there's dilated loops, they recommend the upper GI, fluorescent upper GI. And usually if there is obstruction, I'm going to show you the pictures, then a baby malrotation volvulus still improve otherwise, because its timing here is matter. It's not like duodenal atresia. You have a time, baby already atresia long time, baby has the ileal atresia for a long time, so there's no acute vascular or bowel loss risk. In volvulus, there is a high chance of bowel loss, so you need to do it quick. Open and then look at if there's any viable organ, bowel, and then if there's any twisting, untwisted and fixed. Okay, so let's talk about it now. So I give you overview. So malrotation, we said failure to normally rotate of the bowel. There's something called, there's something called non-rotation. So we have either malrotation and we have something called non-rotation. So what's the difference between? Malrotation, the bowel is already rotate and then failure to descend or continue rotation. So bowel is already rotate and then stop rotating. Non-rotation, it's never move. So it's always on the cecum is going to be on the right. Sorry, cecum is going to be on the left lower quadrant. So it's not rotate, never rotate. So it's going to be on the left side, and then the rest of the bowel is going to be on the right side. So if you see the cecum, when you do the enema and you see the cecum on the left side and the rest of the bowel on the right side, that's called non-rotation. And usually it's less complex than malrotation. Okay, we discussed about the risk of malrotation, and we said the volvulus is the acute emergency because can cause acute ischemic bowel necrosis. Okay, and baby might lose the bowel. The incidence of the malrotation, if you have symptomatic, so we said that a lot of time you didn't discover it, but for the symptomatic malrotation itself, it's the incidence is 1 to 6,000. Okay. One to 6,000. Malrotation, the incidence in general, 2 per 1,000, but because of symptomatic we discovered early, that's 1 of every 6,000. Around 30% of patients of malrotation presented by 1 month of age, 58% by 1 year, 75% presented by 5 years of age. So that means babies, we might miss malrotation. It's okay because it's hard. If baby doesn't have obstruction, it's hard to diagnose. And the moment baby has, either they open accidentally, for example, appendix, or for any reason, they might find malrotation. So it can't be accidental finding. Or it might be symptomatic when baby has duodenal obstruction or volvulus, then that's usually present with symptoms. Whenever you have malrotation, and that's the usually board question, you need to make sure that baby, you need echo to make sure baby does not have congenital heart defect. Okay. Sorry. Heterotexy. So that's the number one. So you need to do echo, make sure there's no heterotexy. What other finding that might be associated with malrotation? It could be diaphragmatic hernia. It could be omphalocele or gastroschisis. It could be atresia, either esophageal or the intestinal atresia. It could be part of syndrome, Cornella de Lange syndrome or Brown-Belly syndrome. So those, make sure that among all these, the most important, usually they love it in the board, the heterotexy, but can be associated with any other malformations. Clinically, we discuss about this. How we diagnose malrotation. So number one, baby non-specific finding, either partial or complete obstruction. So when we said malrotation, we are focused mainly here on the volvulus, because malrotation can be asymptomatic and unless they have obstruction. If the baby start having obstruction or volvulus, then it depends, either partial obstruction or complete obstruction. So when you do the X-ray, it could be non-specific pattern. Here the stomach, here duodenum. You can see non-specific, because what happens, baby was completely fine. He has malrotation, but never been obstructed. So you can see the distal bowel, but then all of a sudden obstructed. So you might, when you do the X-ray, you might see the distal air. So it doesn't exclude. The diagnostic of choice, whenever you have bilious vomiting, always start with upper GI, especially baby who just born, okay? If baby has, so what you're gonna see, either you will see, if you have baby complete obstruction, you might see something called bird beak appearance, okay? If baby has partial obstruction, then the contrast gonna go through the partial obstruction, and that's create something called corkscrew appearance. So either in the board, they're gonna bring you like description of X-ray or barium image. Whenever you see corkscrew and dilatation proximal, then you know that most likely volvulus till improve otherwise, stat surgery till improve otherwise. If you have complete obstruction, you might see something called bird peak appearance. Here I'm trying to show you guys the non-rotation, how it looks like. So when you give a contrast, you go all the way, descending column, you have a cecum here, and then ileum. So the cecum located in the right lower quadrant. If you give it, if you see here, like this, go all the way, and now you have a cecum, and then dilatation, that's the cecum. The cecum now located where? In the left upper. And then the bowel, the small intestine located on the right side, that's called non-rotational. Okay? The management. So once you have the suspicion of the malrotation with volvulus, then you take the baby to the OR, stat OR. It's not like I'm gonna wait for tomorrow, I don't have time. No, that's the stat OR, because the time is matter here. Usually the surgeon recommends pre-op antibiotics, baby already MBO, start fluid, and they took the baby to the OR for the X-lab, open and see. Majority of them, what they do, number one, they do something called LAD procedure. They took off the LAD, the fibrous, dense fibrous tissue. They take it off, and then what they do, they clear the obstruction, and you can see here the LAD. They try to take it off, and then untwist it. If there's any, they look at the bowel, untwisted the bowel. They look at the whole bowel. If there's any ischemia, if it's completely viable bowels, then what they do, they replace it back, rotate everything back to normal. They fix the bowel to the right position, and then they took the appendix out. Usually that's what they do. They take appendix out. Okay? So if the baby, because here the appendix located and usually at the right upper quadrant, so there's no confusion, they take it off. So next time baby presented with abdominal pain, they know that the appendix is out of the equation. Okay, so the volvulus is the true emergency. That's another case that we have it this week. Baby presented with 23-weeker. He was in the unit, completely fine, and then he presented with abdominal bilious vomiting. We keep baby MBO, it's constant bilious vomiting. Each time we feed baby bilious vomiting. Usually when you have that presentation in preterm late, around a month, always necrotizing enterocolitis on top of your differential diagnosis, because that's risky. Usually that's age. Late, necrotizing premature start late. We said in full term, usually early. But if the baby was full feed, 26 calories, all of a sudden starts sick looking, abdominal discomfort, screaming, or fuzzy crying, each time you feed the baby, he's vomit, and they recorded, or they said this baby has a bilious greenish yellow. Keep baby MBO, do the chest, do the KUB, abdominal X-ray. So the first abdomen X-ray, you can see here, non-specific bowel distended. It's very important. And please go to my presentation for necrotizing enterocolitis to know what you are looking for. Here, I did not see any nematosis. You can see it's non-specific bowel patterns. There's some thickening in the bowel loop or wall, sorry. And you can see here there's air all the way down in the rectum. I kept the baby MBO, reblogal with suction, and then I repeat the X-ray second day. So the second day X-ray, and I called the surgeon. So here you can see there's the stomach, some bowel pattern here, and there is bubbly sounds here. Most likely, it looks like close to the nematosis, but most likely stool. So when we called the surgeon, she looked at this. She said, I'm going to do upper GI. And that's the upper GI. We did fluorescent upper GI. We give the contrast. It's filled the stomach. And then she followed until here. What's interesting, you can see here, there is cut line. You can see, sorry, you can see it's the contrast is stopped here, nothing after. In her differential diagnosis, malrotation till improve otherwise. She took the baby to the OR for the X lab. And because her main concern might be some volvulus, complete obstruction. When we did the baby OR, what she discovered, yes, baby has malabsorption, but luckily this baby doesn't have volvulus. Baby has duodenal obstruction. So that means the LAD band obstruct your distal duodenal here. That's the LAD, and obstruct your distal duodenum. The food does not go farther down. And this baby, because he has been presented late, because baby has partial obstruction, and now it's getting worse and worse until now it's complete obstruction. Initially, baby has some emesis. They think his baby has a reflux, which is very common with the premature babies. But now, after this presentation, bilious emesis, we discovered this baby has malrotation at around 1 month of age. Okay, and he had that duodenal obstruction because of the lead. Hopefully, it's clear. Okay, very good. Now we're going to discuss about Meconium ileus. That's another topic. They love it in pediatric board. They love it in the NICU. Okay. The very tricky here. If you have, somebody asks you, if you have a cystic fibrosis baby, what's the early presentation occurred during the neonatal period? Is Meconium ileus. What the chance that baby has cystic fibrosis develop Meconium ileus? It's around 20%. Again, if baby known case of the cystic fibrosis, the chance that he will develop Meconium ileus is 20%. But that's the clue here. If you have baby with Meconium ileus, 90% chance that this baby has cystic fibrosis. Again, if you have baby who's cystic fibrosis, From all the symptoms that they can present, 20% they will present it with Meconium ileus. But once you have Meconium ileus, there's 90% this baby will have cystic fibrosis. Hopefully clear. What happened with cystic fibrosis? Cystic fibrosis, everything, the whole secretion is very sticky, hyperviscous. And when you have the stool, so all the secretion, bronchial secretion, salivation, everything is very thick. But if you come to the bowel, the meconium, because it become taken away, all the secretion become very thick, viscous, that can obstruct. And the obstruction in Meconium ileus is very clear, that's mainly in the terminal ileum. So the most common, and that's why we call Meconium ileus. That means it's the ileus, the slow motility, and ileum, the most common is terminal ileum. So that's number one. So it's not, this one is not large bowel obstruction. This baby presented with small bowel obstruction because of the Meconium ileus or Meconium. So you can see in this image, the Meconium is very thick, viscous, obstruct your bowel. And here, depending on the duration, how long it is being obstructed, the distal column will be determined. Okay? Or the column, the whole column. The associated finding with Meconium ileus can be presented with also something called Meconium peritonitis. That means small perforation in utero. And how can I know that baby might have Meconium peritonitis? Either antenatal calcification, like in the peritoneum, or after baby born, you do X-ray, you will see some calcification. That's called Meconium peritonitis. The second associated finding, it could be volvulus, intestinal necrosis, because can be the stool can cause kind of ischemia and can end up either perforation or necrosis. Okay? Usually how they present it, usually presented early. Baby is going to be sick, 24 to 48 hours of life, absent stool, baby presented with bilious vomiting. And we said why bilious? Because of the obstruction distal to the ampulla vata, which is the second part of duodenum where the bile secreted there. Plus minus, baby might present with abdominal distension if late presentation, but just sometimes baby presented with bilious vomiting, absent stool. When baby absent, usually baby pass meconium within first 24 hours of life. If the baby does not pass meconium beyond the 2 days, then you think of the either Meconium ileus or we always say Hirschsprung disease still improve otherwise, correct? So here we need to differentiate the differences between both. Also, so that's the presentation antenatal. Also, baby, if the, postnatal, if the antenatally, they might present it with something called echogenic bowel pattern. Or they might call you intrauterine as a high risk. They will say this baby has intrauterine calcification. Okay. There might history of polyhydramnios. Usually polyhydramnios obstruction ileum and above. Distal obstruction polyhydramnios is less likely. So here, because of the obstruction, baby might have that, or the intrauterine, they might describe it as a polyhydramnios. They might describe it as a fetal ascites. We said peritoneal wall calcification or intra-abdominal cysts. That's all can be indicated of Meconium ileus, or it can be normal. Let me ask you guys, if the baby, if they call you baby born and they call you, they said the baby has intrauterine calcification, what do you want me to do? Mom, she just born and the baby has intrauterine calcification. Or let's take intrauterine. If they said not intrauterine calcification, we'll discover later on. But the baby has hyper-echogenic bowel. Usually we do nothing. We observe. We start feed because it might be normal finding, and majority nothing gonna happen. You start feeding the baby. If the baby's tolerate feed, everything's fine. You good. If the baby start emesis, then baby need to be admitted in the NICU. That's what we do here. Okay. Evaluation and diagnosis. So if you have the baby abdominal distension, you are baby start vomiting, or abdomen soft but baby or full but soft, baby has bilious emesis. Okay, you do X-ray. X-ray for the Meconium ileus, it can be non-specific. Okay, just distended non-specific, or you might see clear fluid levels, and you can see here very clear fluid levels. Okay, and you can see here nothing on the distal. You might see characteristic something called bubbly, which is, you can see it here like bubble, so bubble, it's bubbly appearance on the bowel. Let me take it off so you can. Okay, or you might see intrauterine calcification, and usually you will see it here, calcification. So those characteristics on the X-ray. So it could be non-specific, just dilated loops. It could be bubbly appearance from the meconium, which is here, the same pictures. Or if baby has perforation, microperforation, you might see the calcification we call intrauterine, or the bowel calcification that's mainly reflect the intrauterine perforation, and people, they love it in the board. Intrauterine calcification in the X-ray, you look for the answer, intrauterine calcification or meconium peritonitis. Okay, that means meconium perforate and create peritonitis. Meconium peritonitis. That's the board question. So that's the one of the board they love to ask for. Then we said you're gonna do barium. When you do barium, because of the baby meconium ileus, depend on the timing here. If the baby has meconium ileus for long time, it creates like ileolatresia. So what you're gonna see, the all the way, you can see that here you inject the dye contrast. You can see there's some filling defect with the meconium, but you can see the colon's very microcolon, small colon, atrophied. And then you can see here like bubbly, or the filling defect. That's the best term, filling defect, okay? In the right column, close to the distal ileum. That's indicate meconium ileal or ileal atresia till improve otherwise. Okay? Very good. That's the picture of intrauterine calcification or intra-abdominal calcification. You can see all these whites. That's baby has meconium peritonitis, non-specific abdominal distension, and calcification. It's very clear. Again, we give a contrast to this baby. And how do you know this meconium, not hairspring? Sometimes it's difficult if you have hairspring totalis, all its colon is micro, or all the aganglionic, but majority of the hairspring is the rectum or rectosigmoid. So here you can see it's a little bit dilated and then start narrowing. So there's the hairspring. It's less likely, but still you need to take the biopsy and send it to make sure that you are not dealing with hairspring. But you can see here, there's filling defect. You can see the meconium pattern, and you can see the microcolon all the way and ending here. If you pay attention more, you can see proximal bowel distension. You will see it all the way. That's the proximal to the meconium ileus or intestinal atresia. The bowel is all dilated. So here the white is the contrast here. Let me clear it up. So we can do it two different color. So that's the, we give contrast, filling defect, and then ending here. If you pay attention more, you will see the bowel all dilated here. That's the proximal to the obstruction. Okay? This case, you need to take baby. Sometimes, if you are suspicious of ileal atresia, like this baby, what they do, they try to give water-soluble contrast enema. So if your suspicion is very high, baby has the ileus or the bilious vomiting, you did the upper GI, there's no malrotation, you did the enema, it appears as there is a filling defect, so you think it could be meconium plug or meconium ileus, and then you notice that there is go all the way and ending at the terminal ileum. You might try from the beginning, or you might second time you try the water-soluble contrast. Okay, so usually that's what they use, hypersmolar or water-soluble, and that's successful rate up to 60% of time. And if the case, you always send for the cystic fibrosis. You need to do the test for cystic fibrosis. If it's failed, then you might try again. So it doesn't mean that you need to take baby OR. You might try it twice or 3 times, and then if it doesn't work, then you take the baby to the OR after 48 hours. What's the complication of the ileal atresia? It could be or meconium ileus. It might end up baby has meconium ileus and then in them what ileal atresia or stenosis. As I said, it might end up with ileal perforation and meconium peritonitis, the stool coming out intrauterine for a long time, and that can cause meconium peritonitis. Few cases it might end up volvulus with or without pseudocyst formation. Okay. We have 15 more minutes. Let's continue. Now we're going to talk about large bowel obstructions. We will start with the colonic atresia. It's 1 to 1,500 to 1 to 20,000 PERT. It's considered the rarest atresia of the GI. It's not common. It's very rare, but has associated with other GI or skeletal abnormality. The pathophysiology is similar to the ileal atresia or jejunal atresia or ileojejunal. It's also related to the vascular atretic blood vessel or vascular supply to the colon. Presentation, usually they presented with dilated loops, non-specific. As I said here, because of the distal obstruction, polyhydramnios is not often be present. And the obstruction sometimes does not appear early, so it appears a little bit after 24 hours, not like proximal obstruction. This is the distal. So it's time for the stool to go all the way, the food go all the way to the distal, and then baby's gonna show symptoms. If baby has completely atresia, you will see no meconium. Also, those baby can be presented with pneumoperitoneum, up to 10% of cases, perforation. Once you have the baby with abdominal distension for unknown reason, they might present it with any. So the presentation usually similar, just a little bit late, but it's very hard. So it's not like, this baby has colonatresia. I know just by looking at the X-ray. It's very hard. So usually you do X-ray, you do the barium. Okay, and you can see here, when you go, you will see all the way. So initially normal, so it's not like hairspring. And then you can see the small colon. Small, and ending, there's cut off here at the mid-transfer colon. At this case, you need to open and see. If you focus, you can see the proximal dilated loops. I did not see cecum here. So that means there's obstruction prior to or at the transfer colon before at the descending or the cecum. Okay, so again, on the KOB, usually non-specific. If completely obstruction with the ileus like this, colonic atresia, you might multiple fluid level, and you will see there is no air under the rectum, because what? Baby had atresia. It means happens long way during the pregnancy, during the development early. So there's no way to the bowel or the gas go all the way down to the rectum. When you give contrast, you will see normal colon, and then you will see the microcolon, and then there's cut off point. Management as any intestinal obstruction, the same. MBO, decompression, start broad spectrum antibiotic if you concern perforation or ileus, because sometimes we don't know. It could be perforation, it could be ileus. You do the enema. Once you have this result, usually the surgeon, they will say, okay, it looks like there is ending here. Most likely there's somewhere there's obstruction. It could be colonic atresia, it could be something else. Let me do the X-lab and I will open and see. And then majority, when they open, let's assume that we found colonic atresia. So the bowel, that's the here. And then there's atresia, nothing. And there is here, the rest. Usually what they do, as we discussed the last time, they bring the colon outside, that's the skin here. And that's called the colostomy. And they bring the second edge here, that's called the fistula. And usually they leave it for a couple of days and then they place that, or a day or two. And once the baby starts stooling, they place the colostomy back. So now you have the colonic or colostomy, and you have the fistula. Colostomy, that means all the way up, colon. Okay, and then the fistula site down here on the road. So until the baby is growing. Is that all the cases? If the fistula is very small, then most likely they're gonna just reanastomosis and that's it. But if the fistula is long distance, there's no way to bring edge to edge together. Usually they come with colostomy and fistula. And then they ask the baby to monitor. And then once the baby grow up, later on, they will do the reanastomosis, or gonna open and the revision. Hopefully it's clear. Okay, small left colon syndrome. Small left colon syndrome, I need you guys to remember two things in small left colon syndrome. Number one, it's very common, or the most common associated with infant diabetic mom. If they bring you a story with infant diabetic mom, and then they show you the image, always think of if they show you microcolon on the left, microcolon on the left side, and then in the story they mention infant diabetic mother, look for the small left colon syndrome or transient obstruction if they want to know the pathophysiology, or they want to know what's the course of treatment. Usually monitor baby clinically because that's transient obstruction. So let's go one by one what this means. So it's commonly associated with infant diabetic mom. That's number one. It can be associated with maternal hypothyroidism, magnesium exposure, or prematurity. All of these, it's transient. All of these, it's transient. Okay, you have the motility issue, or you have prematurity, but the majority of cases, they will come with infant of diabetic mom. It's functional immaturity of ganglionic. So it's not like Hirschsprung absent of aganglionic cells. Here, no, there is just immature. And majority at the level of the descending colon or rectosigmoidal. So at the left side, where's the rectosigmoid or the descending. It's transient obstruction. Baby presented like any obstruction, abdominal distension, bilious or non-bilious vomiting, failure to pass meconium. You do the barium or X-ray, multiple distended loop. With infant of diabetic mom, you do the contrast enema. The contrast enema, you will see the small colon with dilated or dilatation proximal to the small colon. And the colon is tiny, small. And that's usually the board, they love it. They just give you the picture and a little bit story of the infant of diabetic mother. Okay? Whenever you have it, sometimes it's very hard to differentiate between left, sometimes if involved also the rectosigmoid, it's very hard to say, is it Hirschsprung disease? It's always make sure that you rule it out, take the biopsy to just rule out Hirschsprung disease. The majority of cases, just you're gonna monitor those patients. It's partial obstruction, transient, it's gonna go away by the time. Next, Meconium plug syndrome. That's very, very common in premature babies. When the baby is presented with intestinal obstruction or the abdominal distension for unknown reason. And usually when involve the surgeon, she look at that, they do x-ray, there is dilated, non-specific. Usually here, you're not gonna see fluid level, more of non-specific. It might be, but usually otherwise healthy baby, they might present with emesis or bilious or non-bilious vomiting, but usually it's mild. It's not like the, and usually it's not immediately after birth. Usually it's not like a few hours after birth, usually second day or third day. It can be associated with infant diabetic mother. It can be associated with hairspring disease up to the 38%. Magnesium exposure, like what we discussed about left small colon syndrome, or cystic fibrosis, because the meconium is very sticky, can cause meconium plaque. So what does mean meconium plaque? The same like meconium ileus, but just in the colon. So it's large intestine, not small intestine. And the meconium block and obstruct the bowel. Why it happened, nobody knows, but there is a certain explanation theories. It could be also transient or functional colonic immaturity. In the baby who is diabetic, we said this common also in infant diabetic mom, because baby has hypoglycemia risk, neonatal hypoglycemia, increase the glucagon. Glucagon decrease the motility of the left colon. How we differentiate all these type? In the small left colon syndrome, number one, it's mainly affect full-term baby versus meconium plug mainly affected premature baby. Presentation, they might present the same pictures. When you do the barium, in the meconium plug, very rare you will see microcolon. Versus if you have the left colon, you will see, as we said, left small colon or left colon, small left colon syndrome. So the colon is microcolon. The obstruction in the large bowel versus the meconium ileus, the obstruction is the small bowel. The meconium ileus, because it starts super early, usually they have the microcolon of the bowel in the contrast enema. And usually baby more sicker than baby with the meconium plug. And majority of the surgeon, when they examine, sometimes when they think is more with meconium plug, they examine the anus. The anus with the baby with hairspring disease, you will see tight. And that might be give a clue, but it's not always clinically, it's not always right. How we diagnosed, we said we're gonna do x-ray, we're gonna do the contrast enema. We usually give hyperosmolar contrast or water-soluble contrast enema. And majority of time, when you flushed, you will see, or when you do the flushed, it's gonna come out. But also when you give the contrast, what's gonna happen? You will see the more than regular terminal ileum or meconium ileus, you will see the filling defect and the contrast. Okay. So you see something called double contrast impression, some area of thickness and some area of the light. So here filling defect and here the contrast. You can see there is area of the management, as I said, 60%. When you do flush, you might end up, some patient, they required, as I said, serial hyperosmolar contrast. Because you are not sure and you don't want to miss hairspring disease, it's a good idea to make it habit and take the biopsy in those cases because you don't know, and it's good to discover hairspring disease. If there is no Bass meconium within, after you do the serial gastrographin or hyperosmolar contrast, if nothing coming out in next 2 to 3 days, then you might end up surgery. Okay, any question? I'm gonna end up here, hairspring disease. Next week, inshallah, we're going to talk about hairspring disease and imperforated anus. So we will finish the rest of the large colon, which is hairspring disease, and then we're going to talk about rectum and anus. The main topic is imperforated anus. And then if we have time, we're going to talk about the abdominal wall defects, gastroschisis, and omphalocele, whether we're going to do it in the together or we're going to do in separate lecture. Any